Hi, good morning. This is Terry Kuti, founder and director of Deep Sea Foundation. Welcome to the educational channel where we talk about a number of topics related to breast reconstruction. So honored today to be joined by my guest, Dr. Robert Allen. He is the pioneer of the muscle-sparing DIEP flap and founder of the Center for Microsurgical Breast Reconstruction. And I want to give the viewers today just a very brief story about how I met Dr. Allen. We met in January of 2020. We're filming this right during the pandemic, and we met in January of 2020 at a microsurgical convention in Fort Lauderdale. I was so fascinated by his work, but mostly thrilled to meet him. You're considered the father of DIEP flap, Dr. Allen. So welcome to the program this morning.
Thank you, Terry. It's a pleasure and honor to be here and to talk on your program.
Yeah, and I want everybody to know, during the pandemic, all of these connections and Zooming and everything, the name in the corner of the screen is supposed to be Dr. Robert Allen, but we kind of switched computers this morning. So what you're viewing is another name, and I want everyone to know we are speaking to the Dr. Robert Allen, the pioneer of the muscle-sparing DIEP flap. So Dr. Allen, I have a question for you. In my conversation with women, a lot of them will ask me a question, and they'll say, what does that mean when they're going to clip my blood vessels before my DIEP flap? Well, this is something that very few microsurgeons are doing, you being one of them. And I thought, who better to chat with us about than, the person who really has spearheaded something called a delayed DIEP phenomenon. So I really want you to explain this to the viewers today so they know more about it. And I'm going to leave it there and let you take over.
All right. Well, the DIEP flap came about in 1992, and it was a way to only transfer skin and fat without the muscle, and make it more of a true tummy tuck in terms of donor site, not preserving the muscle. And it became, over time, looked at as the gold standard for autologous breast reconstruction using body tissue. And but as it turns out, every case can be a little bit different based on the person's particular blood vessel anatomy. And so after about the first 10 years or so, we learned that we could do pre-operative imaging of the key blood vessels and see what particular anatomy that person had. And so that was very helpful, knowing what you would encounter with that particular person when you did the procedure. And what we hoped for was if they had a single dominant perforator. So if their anatomy, the perforators are like sprinkler systems all over the body. These sprinklers come up either through or between muscles, and they irrigate a certain volume of tissue. And so the volume they would irrigate, that's how much you could safely transfer. If you transferred more, then you would have inadequate blood supply to the periphery, and that part would not survive or would form like fat necrosis. And so, unfortunately, probably only about 15% of people have that particular anatomy that lends itself to a reliably big territory. And we are often doing bilateral breast reconstruction, where we have to make two breasts from the abdomen. And so sometimes we would come up short of volume because of the limitations of the tissue as well as the territory. And so to incorporate what's known as the delay phenomena with the DIEP, it's a way to make the operation better. And so it's like custom designing every DIEP flap to the ideal situation, which we don't encounter that much on its own. It's been known for a long, long time, and particularly got real popularized in the early part of the 20th century with a lot of the flap reconstruction that was done for people injured in World War I. And Sir Harold Gillies popularized the tube pedicle flap. And it's long been known that if you transfer the tissue in more than one stage, if you do an operation first before you transfer, then the survival is much, much better, and the volume that you can take is essentially like doubled. And so, but that was back way before the era of microsurgery, transferring tissue around. And so when microsurgery began to be used to transfer tissue in the 1970s, then people kind of forgot about the delay phenomena with the multi-stage procedures. But it was a good concept and it worked very, very well. And it so happens one of my mentors when I was a general surgery resident was Bert Myers at LSU in New Orleans. And he had written a book titled Skin Flaps, co-authored this book and published in 1975. And I was a general surgery resident in 1976. And so I credit him with giving me inspiration to decide to become a plastic surgeon. And one way of looking at it, there are two types of plastic surgeons. You're either a flapper or a grafter. And I'm the former. And so one of the chapters in this other book I've got is titled Flap Happy. And so a flap brings its own blood supply when you transfer the tissue. Whereas a graft, like a skin graft after a burn or something, depends on the blood supply where you put it. So you just have good blood supply where you lay it on and it will take in that fashion. But so Bert Myers in New Orleans, who was a general surgeon, but he had a nice laboratory at the VA hospital in New Orleans, and he did a lot of research on the delay phenomena, particularly that was still very, very top notch today. And unfortunately, not too long after his book came out, plastic surgery shifted with an interest in muscle flaps, because it was shown that with muscles, you could rotate them or transfer them microsurgically. And you could take the overlying skin and fat reliably. And so we essentially had any muscle in the body could be transferred. And so that kind of consumed all the plastic surgery journals and all the residency programs, and among other things, led to the tram flap, which is a rectus abdominis myocutaneous flap, taking skin and muscle. And so I was coming along during that era, which when I've come to regard that as kind of the dark ages of plastic surgery. And because when we think about what plastic surgeons are called on to do, whether it's breast reconstruction or facial reconstruction or extremity reconstruction, hand reconstruction, for the most part, a skin flap. Skin and subcutaneous tissue is the ideal material that needs to be placed to reconstruct. And there are a few instances, say for instance, if you need bone replacement, like missing a mandible or such, or if you needed muscle to reinnervate, say if you had paralysis of the facial muscles and you put a muscle in to make it work. But 90-some% of the problems in plastic surgery will be best solved with the skin flap. And so a lot of that early work had gone on in New Orleans, and so when I started thinking about all these muscle flaps with all you heard about, that helped inspire me to say, wait a minute, we need to shift the emphasis back to just transferring the skin and fat. And wouldn't that be nice with the breast? And then I remembered a book from my father's library, who was a surgeon, and let's see, it's called The Principles and Art of Plastic Surgery. It's a 2-volume set, came out in 1957. And my father, I think he must have gotten an early copy, because I remember I was in elementary school. I remember falling in love with that book. Oh, actually, I was in the first grade, I think. But it was in the library at the house, and I would go and look at it and flip the pages and stuff, and I was just totally fascinated. And I would bring friends over, and we would look at the pictures and look at the stuff. And so it was kind of an early influence. And
you were destined to do this, Dr. Allen. If you were doing this as a child and had that interest, you were destined to do that. You know, it's so interesting, not to interrupt your conversation, but when you, oh my gosh, look at that. When you talk to me about, you know, what plastic surgery is all about, 2 words that just resonate with me, and it has to do with this conversation, are form and function. So, you know, muscles, yes, they have a good blood source, but then, you know, when you started the pioneer work with the DIEP flap, to me, that's where the word function comes in. Because when you lose the ability of that rectus muscle, you lose your sit-up capability. I've heard women that have had trams. I know everybody's different. I'm not generalizing here, but they talk about having to roll off exam tables, you know, because they don't have that rectus muscle. And so I think about that form and function and how important, you know, the transfer between the tram and the DIEP is, and so interesting to hear you talk about this.
Right. So the form and function are very, very intertwined. And so the way the body is made is for the most part, it's the best it could ever be. And so to reconstruct it, you want to replace like with like. And so, I mean, in the early days, a lot of the reconstruction that I was doing, microsurgical, was lower extremity reconstruction. Say a person had an open fracture of the leg and they'd lost covering over the bone. So the fracture couldn't heal unless you had good healthy tissue over the bone. And so the standard for years was to transfer a latissimus muscle from the back, which is also used by some for breast reconstruction, with or without skin, say with skin and fat. So we would have a person with a bad leg wound, and we would do a long operation and go talk to the family and tell them what we did and everything. We would often have the legs suspended so there'd be no pressure or anything, but it was still there for all to see. And they would come in and see the patient in the ICU, and they were kind of aghast because instead of normally just like a quarter of an inch of skin over the bone of the lower leg, the shin area, there was about 4 inches of big muscle and then fat and then skin. So it was sticking way up, and it looked very, very bizarre. We were happy because we had good blood supply to allow the bone to heal. But their question was, well, doctor, when are you going to do the plastic surgery? So,
Well, it's
but
like the whole picture of Gillies with the flap in the one you were referring to in
yeah.
World War. Yeah.
So the best you could do really to cover the shin area where the skin has been knocked off or died is to put a vascularized skin and a little bit of fat under it. So if it looks good, it's going to function better too. And so the other thing is you couldn't get your pants on, or if it was in the ankle, you couldn't get your shoes on. So it's not only that you lose function when you take the muscle, but also it doesn't have any business being in a lot of these places we're putting it. And so the delay phenomena was utilized, and even goes back probably before Christ with forehead flaps for nasal reconstruction. And it had been used and then extensively after World War I. But then it was kind of forgotten about somewhat. But to bring that back, you take a very, very powerful tool with a very, very good scientific basis, and you couple it with the DIEP, and you make it a much, much better operation. And a complaint might be, well, isn't that an extra operation? And the answer is yes, because it's done in 2 stages. But often the patient is going to the operating theater or operating room for something, and you can do it at the same time. But the delayed procedure takes about 45 minutes to an hour, and it's like an outpatient procedure. And
walk us through that, because it is outpatient, and kind of walk us through what is done ahead of time to kind of produce this super blood vessel or this super highway for you to work at once you get into the operating theater. Because you do, yeah, you do the CT angiogram first to map it. So just
or the MRA. I prefer MRA because there's no radiation to the patient, but you see the vessels to know what their particular anatomy is. And then normally you see all these sprinkler systems coming up. And so typically, if you went in there and you just kept one for the DIEP flap, it would cover past the nearest perforator and halfway to the second one.
Mm-hmm.
And then it would run out because it would just hit a wall. And so that would limit it. And so between the 2 sprinkler systems are usually like choke blood vessels.
Mm-hmm.
And so since one is supply, they both supply, and they won't let the blood go back and forth at ease. But if you take out one, then it will allow blood to get through that one. But when it gets halfway to the next sprinkler system, it stops. Now, if you go in ahead of time, which is what you do with the delayed procedure, so you select and keep the one blood vessel that you like, and then the adjacent ones, you clip them, so you divide them. And so when you do that, then it opens up the choke vessel. So then it creates the superhighway. And so instead of stopping 1.5 perforators away, it can go 6 perforators. And so it doesn't die when you do that. You leave the lateral part of the abdomen, you don't cut the incision all the way. The rest of it's like the final incision, but you leave blood supply coming in from one way, and then you got it coming in from another. So each one will go like halfway, but they communicate. So then when you come back later and you divide it to transfer the tissue, then everything is opened up. So you can take literally twice the territory, and you can have much better blood supply. And then when you transfer the DIEP on only one vessel, you would pick it. So you prefer a low one to give a nice cosmetic low scar, which often is missed with a typical DIEP because the only good perforator might be kind of high. But if you just pick one that's a little bit lower, then you can divide the others and it will get bigger. And so when you and we've studied them with either thermography or ultrasounds. And so we demonstrate that, after we do the delay, clipping off the blood vessels that we're not going to keep, then the process takes about 3 to 4 days for the delay phenomenon to occur. And it's permanent. Once it occurs, it stays that way forever. And so, but then if we go back and restudy the blood vessels, we see that what we left has maybe doubled in size, the artery as well as the veins. And the flow through blood vessels and through any tube or water hose or anything is proportional to the 4th power of the radius. And so if you double the size of a blood vessel, then the flow increases not double, but 16 times. So a little bit of an increase in the size is a lot increase in flow. And then when you open up these choke vessels, then you can take much more territory. And so a lot of times people will say, well, we're doing a bilateral reconstruction and we probably come up a little bit short, but we can always do some fat grafting. And fat grafting sounds pretty good, but as I already told you, I'm not a grafter, I'm a flapper. And so I don't really drink that Kool-Aid that much. And so fat grafting, you can fat graft it all you want, but for the most part, it doesn't deliver near as much what the patient or you would want. Most of the fat just kind of disappears. And so rather than do that, if you augmented the blood supply ahead of time with a delay, you wouldn't need to do it. And just like sculpture, if you're trying to make a nice breast, you got to have enough material. If you're trying to skimp, because you don't have enough, then you can't get a good result. And so, it makes a world of a difference if you can get good healthy tissue on the first time, and which also leads into we hear from a number of patients. They might say, well, I saw a doctor and they told me I didn't have enough tissue in the abdomen because I was thin for my body size and my breast size or something. And so in that case, we either have to consider another donor site like the back or the latissimus or the thigh or the buttock or some other area to get tissue from. And before I started doing the delay procedure, which was only like a year and a half ago, before that, I always only did perforated flaps, only did skin flaps, no muscle. But I used donor sites, the thigh, the buttock, the back, or the abdomen. And so about 25% of my practice was where I did not use the abdomen. I never used implants. So a lot of times people say, there's not enough of the abdomen, we're going to use implants. But I would always be able to find some option. But I knew that the ideal donor site for breast reconstruction is the lower abdomen. And certainly if somebody had a tummy tuck, then, you can't really do it. But a lot of people have had liposuction, and you can use after liposuction, even though you wish they didn't have it because they took some of the nice tissue you would have liked. But particularly with the delay procedure, it augments the blood supply to somebody who's had liposuction. And so up until a year and a half ago, about 25% of my patients, I would use a non-abdomen for the donor area. Now I'm using the abdomen on, way over 90%. And in my particular practice, essentially 100% of the times I'm doing a delay and using the abdomen.
Wow.
And so I get to use the ideal donor site, and by pre-designing the perfect flap every time, then it makes the operation easier to teach, easier to do, and decreases fat necrosis and other things like that. So I think it's well worth the extra procedure for the dividends that it provides.
Well, you have really given us a very good description of why this is done, and the fact that it's done in office, 2 to 4 days prior to the longer DIEP flap, the transfer of the tissue. And this clipping, now we have a word that we can use that patients can ask, the delayed phenomenon. But again, I really want to just emphasize that not all microsurgeons are doing this, but it never hurts for patients, I don't think, to at least bring it up and to ask about it. And I love the analogies that you use today, Dr. Allen, because really what this is doing, the benefits that I gleaned today are the fact that because you are supervascularizing, that's my term, but it's from what I'm understanding you talked about today, you're minimizing the risk or the chance of fat necrosis. Also, one of the benefits is that you are able to get more tissue to use for that sculpting. And what artist, which I consider microsurgeons and plastic surgeons to be artists, what artist doesn't like more material and tissue, in your case, to use? So it's just been a wealth of information, and I really appreciate your time today.
Well, it's always good to talk about it, and as happens with everything, and certainly when the DIEP, when I first pushed that forward in the plastic surgery world, it was met with a lot of resistance, particularly in the U.S. It seemed to catch on much quicker in Europe and Asia and other places, but new, when there's a significant shift in the way things are done, there's an amazing amount of resistance. And a lot of my close colleagues and friends and people I've trained and so forth, when I talk about, well, why don't you, combine the delay procedure with your breast reconstruction? And they will, they will, it's like, why would they do that? They have a way they can do that, quote, works, and it would be another operation. And so they always have some excuse not to do it, and they think it doesn't make sense or something. And, but I mean, that's kind of the way any kind of new combination of things. So I think when you get the synergy of these two things, to me, it's like, why would you not do a delay procedure on a patient that's having breast reconstruction? And then people say, well, how, I don't think I could talk a patient into an extra operation. And I like jokingly say, or I'll say seriously that, so I don't really have a problem talking them into it. I tell them all the advantages. And when I was first starting to do it and thinking, well, some patients might not need it and would and so forth. And so Vanessa in the office was, she would say, did you talk to this patient about the delay or something? I said, yeah, I did talk to him about it. And she said, well, and so it had one thing where she said, well, you're going to be out of town, and when you get back, you're not going to have time to do a delay on the procedure. Your schedule's this and that. And I said, well, let me look at it. I looked at it. I said, well, we might get by without it. And so she called the lady, and the lady was like, what do you mean I can't have a delay? And so I'll tell people, it's everybody wants a delay once they know about it. And then recently I think I was in South Carolina or something, and I got a relayed message from a breast surgeon that I work with in New Orleans, and they said, that patient coming up, she doesn't, I know you want to do a delay procedure, but she doesn't need that. I don't think that's a good thing. She doesn't want to have that done. And I'm like, oh my God, I wonder what happened. And it turned out the breast surgeon didn't want to have a delay because it would affect, what day she was available to do the mastectomy, because, when I came back in town and so forth. And so, when we contacted the patient, she said, "Oh, no, I want a delay." And so it's a, it's a nice adjunct. The synergy between the two is almost like Pucell's law, which is the radius to the fourth power. It's just such a powerful combination when you combine what we've known about skin flaps for thousands of years, and we combine it with our ability with microsurgery and technology and instrumentation to do nice things, but this is just something we can add to it, and and so I think it would make more patients a candidate. I always like to give an analogy, and like in South Carolina and New Orleans along the coast, you have these massive live oak trees. And so if you have a massive live oak tree that might be 500 years old, has a big wingspan. But if you have a bunch of oak trees planted side by side, like maybe going into a driveway or something, then they don't have that big wingspan because they interface with the adjacent perforators. But if you take out the other competition, then the territory expands tremendously. So all of these analogies in nature, which all these patterns always repeat themselves, and so they are analogous to plastic surgery and the blood supply, and all the arborization, or you look at a leaf and see all the little veins. This is what nature does over and over again. And so if we can manipulate things a little bit, that's a good thing. Another observation is that a lot of patients, about 30% of patients that get breast reconstruction, with usage from the abdomen, they've had previous surgery on the abdomen.
Yes.
Whether it's an appendectomy or
C-section.
hysterectomy or C-section. So it's very, very common. And so the plastic surgeons are kind of nervous because, particularly before imaging, I said, well, I hope they didn't, destroy the blood vessels we need. But what the flip side of it is, when they go in there and divide, like clip blood vessels off, the ones they leave get much bigger and have a bigger territory. So it's an inadvertent delay phenomenon. And so as far as the mechanism, when you create a relative ischemia or less oxygen to the tissues, then that will stimulate the blood vessels. Say on the arteries, it'll stimulate the arteries to get bigger. And so you get endothelial hyperplasia, the inner part of the artery gets bigger. But it's a one-way street. Blood vessels can only get bigger. They can never get smaller. And so a lot of times we'll have a patient that they know they're going to be needing radiation therapy after the mastectomy. And so we don't like to have the flap get radiated if we can avoid it. So when they have the mastectomy, then while the surgeon is doing the mastectomy, I'll go in and do the delay. And then after they get over the surgery, then they have chemo for 3 or 4 months, and then they get over that, and then they have radiation for 3 months. And then 3 months later, they come back for their autogenous reconstruction. So it might be 9 months later. And we've done this 45-minute procedure, but it's permanent. The blood vessels we divided, they don't grow back. And the connections that have opened up with the highway are permanent. So I point out that it takes 3 to 4 days for it to happen.
Right.
As a practical matter, most of my patients, I will typically do a delay as an outpatient in the operating room. And then 7 or 8 days later, we will do the transfer. At maybe the time of the mastectomy can be done either time. But sometimes it's 9 months, sometimes late. I might be like a little bit scared to do 4 days because it might not be quite enough. The empirically in these books, old books I've got, the book from the early 1950s and going back to World War I think they like to wait like 2 to 3 weeks because it was just all empirical, and they didn't want to risk it. And then the other book from the 70s, it talked about, I think, 8 to 14 days. But the more recent scientific research shows that it occurs quicker than that. And so, but you would have to, to wait. I would wait at least 3 to 4 days, but usually a little bit longer. And any procedure has risk. And if you have the procedure ahead of time, and the person has bleeding after surgery, which can happen with any type of surgery, whether it's appendectomy or a mastectomy. So if they had bleeding after surgery, then they might have to go back to surgery, or they might have to have a blood transfusion. They could develop an infection. They could develop a seroma, which is a fluid collection. So there are risks with the procedure, and it's a relatively minor procedure because you're making your final incisions. You're making all your decisions about what blood vessels to keep and what to take out, and then I lost my train of thought a little bit on that. But,
well, here's what I've learned today. And I have to tell you, the few women that I've heard that have had this done, Dr. Allen, they talk about really the simplicity of it, but also, the efficacy of it too. So we'll wrap it up today. I have to tell you, this has been a phenomenal opportunity for me to talk to the pioneer of DIEP flap, as I call you, and to learn about this delayed DIEP phenomenon, and to give it a name for patients, because I hear it often called clipping off of veins, but you described it so well. Thank you so much for being on the program today. I mean, this has been just such a wealth of information. And I really would like the viewers, if you have any comments or questions when you see this video, please let us know. And we will try to answer them, or let us know about other topics you'd like to cover. Dr. Allen, thanks for being on the program today. And
one other thing I wanted to put out there. So there's a lot of overlap blood supply in the body normally, naturally. And so the two main systems of blood supply to the tissue we like to take below abdomen is either from the DIEP system, which is the deep inferior epigastric artery vein, which is the DIEP flap is named after, or the superficial system. And the superficial system is the superficial inferior epigastric artery and vein. And that superficial system doesn't come through the muscle like the DIEP. So theoretically, it's even nicer if you could use that, because you don't even open the fascia, you don't even see the muscle.
right.
And the problem is the superficial system is, the anatomy is quite variable. Sometimes it's very small, it'll be way too small. And whereas the abdomen, you can almost always use a DIEP unless they've had abdominoplasty or something. So the question is, with the delay, could you convert more patients to possible using the superficial system? And the answer is yes. And so of the ones that I've been doing the delay, I've done about 20% of them have been based on the superficial system. And there's kind of an inverse relationship. And so some people have a more dominant superficial system, some more DIEP system. And you can see that, with imaging and so forth. And so if they already have a dominant superficial system, and then you clip all the perforators so that the superficial system interconnects with all of their territories, then you've really created an ideal flap. And the superficial system, which was the first operation that I did, back in 18, I think it was 1989, was based on the superficial system. And so I was, um, the first 3 cases were very successful, but then the anatomy is not always there. And so I got kind of discouraged, and that's when I started thinking about maybe the DIEP system's more reliable. But like anything, there's good in everything. And so the studies we've done on the superficial system, I've transferred about 15 of the based on the superficial system. The artery is typically like double the size. The flow is like 10 times more. And you can transfer one breast reconstruction, you can transfer the whole abdomen on one superficial system or on one perforator. And so it's another thing to keep in mind. And the superficial vein it just runs, both of them, they just run only in the subcutaneous tissue. They don't come through the muscle. And so it's really the more natural venous drainage of the tissue. So a lot of times people who do the DIEP procedure, they will incorporate the superficial vein as well, particularly if the perforators are kind of small and the veins are not handling the outflow. But with the delay, you can purposely push things one way or another. And so if you see somebody with a big superficial vein, which is not that rare, you leave that and take out all the others, then you've got the best possible drainage. And so, but the superficial, the SIA flap or technique is microsurgeons that do them will tell you it's a little trickier of an operation. And the vessel, superficial system tends to go into vascular spasm more than the other. And it's the vessels coming off the edge of the flap. So there are a lot of ins and outs to it. And I remember I was reading a book by Harry Bunke, who is the father of microsurgery,
Yep.
and a wonderful character. And so he had a chapter on using the bilateral superficial system for one breast reconstruction. And I was saying, well, that's pretty cool because I started the unilateral one, and I'd gotten to know him kind of late in my career and got to be good friends. But he stated very honestly in his conversational type book that something like, we all know that the superficial inferior gastric artery flap is tricky. And there are a lot of ins and outs. And so it can easily frustrate the surgeon. Whereas the DIEP is kind of more straightforward. You follow the perforator, it gets into kind of a real standard deep artery and vein that matches up nicely with internal mammary vein or dorsal veins. And so there's certainly ins and outs. And I think it's yet to be determined how. At first, I thought with the delay that maybe I could be doing like 80% of the patients using the superficial system. But I've kind of backed off of that, even though all of them have been successful. And so I've reserved it to when I really feel like it's the dominant system. And then I will base it on that. And I did a case not too long ago, and the patient, I think, had already had a mastectomy. And I'd already delayed the superficial system. So I was working with one of my microsurgery colleagues who's quite fast, and he was getting the recipient ready. And so we were like, 35, 40 minutes into the case. I said, I've got the flap ready down here. What's the hold up? And he'd been talking with the nurses or something, I don't know. But he's like, okay. Go ahead and take it. I'm about through. And so So I transferred it, and he connected the vessels very easily and efficiently. And I looked at the clock, and it was like, 8:45 in the morning, and we'd already finished. We just like started a little after 7. And it's just kind of unheard of because you hear about sometimes these operations can go on and on and on for hours. And it was like, wow, that was easy. And so, but it wouldn't have been that easy without a delay that I'd done, a week or so before. So it really can be kind of magical, but that particular reconstructive microsurgeon he hasn't really adopted the delay much, and because he's very busy and he has, he's like one of these, like he can't really quite get it, even though he's seen some, pretty startling, examples.
Well, yeah, it sounds like that may have been an influence.
Right. It should be. All
Well,
right.
I think that's what it's all about is, the progression and perfecting this technique.
Right. There are always innovations down the road, and everything is open for change. When something for the better comes along, then if it doesn't hold up to scientific scrutiny, then it's going to fall by the wayside. And I mean, it's relatively early to tell about combining the delay with these because it's not. I don't know. I mean, I wouldn't think more than more than a dozen or more people are really doing this, even though it's getting out there and it's being presented at meetings, and we're working on a couple of nice papers, but we haven't got them submitted yet, and so forth. So time will tell, but I think this is here to stay.
Well, you've presented a great educational forum here for us today. I feel like we have gotten a wealth of information. So I hope this educates more than just the patient today, Dr. Allen. I hope some more people listen to it and learn from the master. Thank you so much for joining us today.
Very enjoyed it.
All right. Thank you very much. Any questions or comments, please let us know. And thanks so much for being part of the Deep Sea Foundation educational channel today.
All right.